Well, welcome to the afternoon session. We've got a lot to get through, and the interested people have come back from lunch. You'll notice that Fernando carried some dessert himself with assistance from his son, so there is dessert for the good people here. This is a session on prostate cancer. I'm delighted to be with Luis Campos Pinheiro and Arnaldo Figueiredo, two outstanding urologists, so we will try to keep us close to time. When Fernando arrives, I think we can all go like this because he's late. So it's a pleasure to once again introduce Elizabeth Heath, who's a professor of medicine in Michigan.
Right. Thank you so much. Again, the critical piece is coffee in the back, so nobody falls asleep because I have to talk about metastatic castrate-resistant prostate cancer in 15 minutes or less. So we're going to go quick, but I want to make this more practical, but not to tell you really how to treat, because many of us already treat these folks, but to maybe talk about emerging topics and some newer discussions that perhaps we should be having with our patients. So we're hoping that the issue of molecular testing also comes into play, just because I think of all the GU tumors, this is one where it's already actively being implemented in our daily practice. I do want to highlight that every time we sort of talk about prostate cancer, there is a context that we put that, sort of the clinical states in. And recently, Howard Scher and many of us put together the Prostate Cancer Working Group 3 papers, and so as a sort of reference, you may want to pull this paper from 2016 that sort of categorizes how we're thinking about things. So we're not really thinking about treating patients pre-chemo, post-chemo, and it's just really defining the lines, first, second, third, fourth, and off you go. And in some sense, I think that also changes the way patients think about things, because there is this tendency, and we all do it, to sort of avoid chemotherapy, and maybe that's not always the right thing to do. So I think putting it into this context is really helpful. The other part that we'll be talking about is the metastatic castrate-resistant space. As you know, and probably will hear, I'm hoping from Derek, because you're talking about AR modulators, there's new data that's in this non-metastatic space that's emerged just as of ASCO GU 2018 that I won't have time to go over, but obviously that's quite interesting in terms of new developments. But I highlight some of the changes in the clinical states models here because this area of non-metastatic may blur into the metastatic space for castrate-resistant disease, because we define the non-metastatic really based on primitive imaging. And as that world changes, we may all of a sudden blur that line to sort of say, oh, I have PSA rising, to there's the cancer. So this is a list we all know. I will spare you from all trials that sort of define how we got here, but I can't imagine many of you in the room that are not aware that these are at least currently the FDA-approved drugs for metastatic castrate-resistant disease. And they come in all sorts of different flavors: chemotherapy, immunotherapy, AR modulators, radium, radiopharmaceuticals, and of course, the bone strengthening agents. So terrific. And it's an active practice. So the question really begins with, what the heck do you do first? And patients want to know what you think because they've already discussed it on multiple blog sites. They've talked about it with not their friends, but their support group and blogs and everything else. And they know that these options exist because really the menu hasn't changed so much. So part of the thinking process as we're sort of advising this folks is this whole concept of disease heterogeneity hits home in this particular subgroup of GU malignancies as much as they have in others in our previous discussions. So there's sort of this understanding, and these are just my thoughts. Again, many of you may practice differently, but to start in our little sort of clinical states model, we have seen these folks, minimally asymptomatic men, low burden disease, they're just starting to progress, sometimes in bone, sometimes in lymph nodes, and perhaps these are options. And I think with whether you're pro-Sipuleucel T or against Sipuleucel T, you know that the less amount of cancers is probably the best subgroup of patients to treat. And then, of course, we've got the AR modulators, which are also really important because they exist and they're also morphing into the M0 or the non-metastatic castrate-resistant space. So I think in general, we all sort of subscribe to this line of thinking. And then with the use of radium, it's mostly men who are symptomatic. And we define symptomatic actually pretty loose. Many of us who practice say, well, but my patient's not on narcotics, so perhaps radium is not the right choice, even though there's no visceral metastases, very, very small lymph nodes. It's just mostly bone. But the way they define it in the trials is, you know, you take a Tylenol or ibuprofen or something for your bone disease, you are now symptomatic. So I've had to rethink that a little bit. I'm not sure if that's enough for me to give radium, but it's certainly something to put that into context, because I think in any other setting, you almost use this a little bit too late. And I know we will be having a lecture on radium a little later. Perhaps that could be something fine-tuned. And then there's this sense that perhaps we have to now revert to chemotherapy if there's visceral metastases. That's at least the expectation from patients. That's certainly borne out by data. But there's many of us that would also treat with an oral agent, whether you have visceral metastases or not. And then, of course, if you have docetaxel and you progress, you might consider cabazitaxel or other oral agents that you haven't had. I think the general gestalt is you try not to do an oral followed by an oral, because there's enough data, at least retrospectively, to say that the second oral agent is not as effective, and you don't get a lot of time and mileage out of that. But there are other emerging areas that I think sort of takes our attention a little bit away from what's on the menu, and in a good way. So definition of clinical endpoints was really, highlighted with the approval of apalutamide just, several weeks ago by the FDA for patients with M0 disease. And their endpoint was metastasis-free survival. So for us, whether it's that or pain reduction, we're always looking for something other than I made my patient live longer, which is fine, but I think the FDA has gotten a little bit more flexible in understanding in prostate cancer, there's a long span of time, and those studies cost a lot of money, and patients want to know and get drugs that are approved much quicker. The other part is what we've been talking in the other tumor types, which is biomarkers. Now, for us, as far as as you remember, for circulating tumor cells, they were FDA cleared by the Veridex technology. But I'll take a show of hands. Does anybody check circulating tumor cells in your metastatic castrate-resistant patients? Raise your hand. And that is a complete zero. And there it is, another drug or another marker that's been FDA cleared, but not practical for purposes of monitoring your patients, because it still is hard for that test to beat a $30 PSA. And that's also the expectations. Obviously, the liquid biopsy world has completely exploded. There's such a group in the US known as the Blood Pack, which is part of the Moonshot Initiative. Lots and lots of people who are extremely bright, lots of companies, lots of folks involved to try to sort that. I look forward to how that will come about. But really, what everybody's talking about is these imaging studies. So, for us, I have patients coming in, not sort of saying, I want my sodium fluoride PET scan, which we used to get all the time until the national registry closed, and now I can't get any covered, unfortunately, as of December 14th last year. But everyone's talking about PSMA. So who has access? Please raise your hand if you have access to a PSMA scan. Wow. And that's what I always say. You go to Europe for that, because I can't get anybody for a PSMA, but we have other PET tracers. So choline, as well as the Axumin scan is emerging. So why is that important? Because one, your patients know about it. Two, they're going to demand it to know where your cancer is. And three, many of them have said, I think I also recognize that you can be treated with a PSMA targeting agent, that it's not just diagnostic, but also therapeutic, and that's certainly the case in different clinical trials. And then, of course, combination therapy. We've heard all morning about newer immunotherapies, but for us, it's different ways of combining orals plus chemo, and you name it. And then, of course, there are newer targets that we'll touch on, and then just one slide on immunotherapy. But before I get going, sometimes you don't need fancy tests to know how your patients are going to do. You don't need to, because this is really nice paper from European Urology. It basically said, guess what? If we have just lymph node metastases, you're basically going to do pretty well compared to the gentleman that has bone plus visceral metastasis. This is often an overlooked set of prognosis. You have this information in your clinic today. You don't need fancy $5,000 tests. What you need is an understanding of what this is so you can counsel your patients appropriately, and maybe this impacts on what you actually select for his treatment schema. And I know we will have a whole session on androgen receptor by Derek a little later, but the idea is that even patients are becoming very savvy on why the androgen receptor matters, especially when they know it's sort of the equivalent to the estrogen receptor. But they know that this pathway is sort of what it is that we're trying to target. So that is something in the mainstream knowledge, at least when I run our advocacy events, I'm often surprised. You know, the knowledge set goes from, you mean women don't have a prostate? Literally, that just happened last year, to, hey, you know, I saw the signaling thing on the website of PCF. I'm like, okay, I have no idea how you know that, but there you go. So how is that important? Because there's a slew of more agents coming down the pike. And we've heard about several of them, but again, the newest one being apalutamide, or in the past, it's known as ARN 509, and perhaps many of you were participants in those clinical trials, but that finally has led to an indication. But as in anything else in oncology, these are the drugs that are now in play, so we shall see what actually will happen in the future. But the hot topic a while ago, and continues to be, is this idea of the splice variants. So let's take a show of hands. Who checks the ARV7 level in the blood? Raise your hand. Right, so you know that there's an actual biomarker that's approved by Epic Biosciences, where you could check that. And the idea is exactly here, that in a full-length AR, you have the ligand binding domain and the C-terminal end, but when you have a splice variant, that's missing. So it's always on. So therefore, you pretty much won't respond to enzalutamide or abiraterone. Now, patients want that, and here's a ready-to-go test. And yet, they don't really ask for it. Doctors don't order it. We don't fight for it because we're not 100% sure that it's the right thing to do, because still our pool of drugs is not 20 like in breast cancer. You still have a limited amount. But is this important for us to know? It is, because we have a slew of drugs that are sort of looking at this. But what if we look at this? Oh yeah, those are the N-terminal inhibitors, and they actually are already in phase 1. So this is a drug, EPI-002, and the phase 1 trial results were reported at this past ASCO. And the reality is, it was a whole lot of pills, like a whole lot of pills, maybe like 12 to 16 a day. And formulation has become an issue, and this is not the home run that we thought it would be. So it kind of puts a little bit of context to this whole, isn't it great we can target that androgen receptor? But even on the N-terminal end, the data is a little bit not as exciting as you'd want it to be, but there are other inhibitors in this space that will be emerging in 2018 and 2019. And then another class of drugs that are already again in play are known as these bromodomain inhibitors. Who's heard of the bromodomain inhibitors? Raise your hand. Excellent. Elizabeth's alone up here. So the important part is, two. And it's important because, again, as patients morph through this menu of drugs, you may say, well, shoot, what are the hot new stuff? Well, this is an interesting way to look at a new drug that's targeting the epigenetics. And we've heard, you know, endlessly, decade after decade about epigenetics. Here's a drug that actually affects the reader function. So for example, let let's see, this drug basically kind of modifies the histone selection and so forth, eventually affecting the MYC mechanism. And it's now in phase 1 trials. These are, again, the inhibitors that are around with or without enzalutamide. It's also with or without abiraterone, just as of a few weeks ago. And they're all available for patients if you have access to the clinical trials. But we do have patients that are savvy enough to know that at least that these are newer drugs that are emerging. And let's not get left out with immunotherapy. So I'm just going to highlight the one thing other than Sipuleucel T. You guys know that there is this whole microsatellite instability high group. Let's not leave prostate cancer out, because right here in the prostate adenocarcinoma, you have about 3%. So that's another avenue, and I have to say that one of my own patients, because we do molecular testing, actually tested positive for that. So all of a sudden, I'm trying to put in this drug for my patient, and it's the weirdest thing because it's not something I'm used to doing, and yet I give pembrolizumab for other indications. So it's a new way of thinking about things, and it's a new way to counsel your patients to say, we really are in the needle in the haystack age, and so it's okay for you to think this way. We think that because this seminal Cell paper by Robinson et al., which really capitalizes the Stand Up to Cancer data, which we were able to contribute to, basically shows that there are actionable mutations in prostate cancer. And it's not something that we're used to thinking about, but it certainly is true, where 23% of these mCRPC patients have DNA pathway abnormalities, and 8% of them harbor germline findings. So if you really do a closer look, you say, well, gosh, here it is. You've got all this AR business. You saw the diagram, mutation, amplification, ligand, whatever. But you have PI3 kinase, DNA repair, CDK, Wnt, and then germline. So do I care about that? I do, because it's not just one thing, which, as you know, is BRCA, 1 or 2, but you have a family of them, ATM, Fanconi's, RAD51B, RAD51A, MLH, MSH2. Depending on the papers, you tack on another 20 of these, and does that matter? It kind of matters, because you might be able to do something about it. Why is that? Because when I order a test, and Derek's familiar with this is what I actually see from the CARIS report that is run at our institution. So we have partnered with them. They're sort of our go-to molecular profiling group, but this is the actual report that gets spat out. Now, we're medical oncologists, and we're not molecular biologists necessarily, and we're left to know what to do with this information. But when you see this, and it says BRCA2, and you've got these mutations that are pathogenic, variant of unknown significance, what you say to yourself is, uh-oh, it seems like it's significant, but I'm not 100% sure I know what to do with that exactly. But in prostate cancer, we actually do know what to do with that. Now, if you go and you say, I'm going to do a liquid biopsy test. So at our institution, we've started sending our blood to Guardant Health. Who's heard of Guardant Health? Excellent. So what is great, it's 2 tubes of blood. It comes in a little box. I send it off. It goes to insurance, and your patients go, boy, I really hope they cover it. But in the same patient, this showed up. So this also was detected in the blood, another BRCA2. So then I say, uh-oh, that was in the tissue that was from the bone, and then this was from the blood, and now we're sort of in trouble. Why? Because everybody here knows the BRCA1 and 2 story is very important, and how they produce tumor suppressor genes. We often forget the significance, how it really affects proliferation of cells in certain ways, and apoptosis. And then the PARP inhibitors. This matters. Why? Because the breast and ovarian docs know, but in prostate cancer, it's become all of a sudden quite relevant. From this Mateo paper, we know that the use of olaparib is very responsive. So January 27, 2016, you now have the FDA fast track. We're just waiting. And there are a bazillion clinical trials in this space. Is this important? Yes, because I now have 12 patients on olaparib based on the data that I presented. The insurance company has approved it, and they're still on it. Now, for us as practicing docs, The key step here is we've got to remember to refer to genetic counseling. This is not something routine in our practice to think about patients in this context. In fact, a family history question is just so you can get the right billing code, so you get a level 5 as opposed to a level 4. So why is that important? Because we are now in the days where you need to refer to a genetic counselor if possible. And in fact, we feel strongly about that because that genetic counselor gets the blood work to show germline, and this person has a BRCA2 mutation. This is one of the tests myriad, but there are so many others in this space. And all of a sudden, when you're thinking about what are the hereditary cancers, metastatic prostate cancer is on the list. We're not used to thinking that. In fact, the NCCN knows that, and as of January of this year, this now has shown up. Personal history of metastatic prostate cancer is an indication, at least by the guidelines, for you to refer. So today is just a quick glimpse and perhaps a little tour of why prostate cancer has become more of a genetic disease, more than we think, and that this whole precision medicine thing is changing the way we do business in the States at least. And now we really have to know and know when to refer for genetic counseling. And I think for us, the question is, how do we incorporate all of that with this new business of clinical trials and your existing medications? So I'll stop there and happy to take any questions.
Thank you. We are running a bit late. First of all, it's a pleasure for me to be here, and I thank the organization for the invitation. If there is no pertinent or very short question, we'd skip the questions for the end of the session. Okay, thank you. So next, Stephen Riggs. We heard in the morning about radiotherapy on penile cancer. Let's see if the story is the same in prostate cancer.
Thank you. So I'm going to talk a little bit on radiation versus surgery for high-risk disease. I think you're going to see this as a story without really any head-to-head data, and that is complicated by what definition you use for this disease. So I'm going to hop into this. So introduction, I'm going to define high-risk disease. I'm going to look a little bit into the definitions that compare to this. We'll talk about the staging. We'll compare some of the guidelines. I'll talk about surgery and radiation. And then I'm going to conclude and just give some additional thoughts on surgery and where I think that sits in this landscape, and kind of a little bit about the technical aspect. There you go. High-risk prostate cancer is hard to define. There's a lot of varying definitions, whether you look at the AUA, the NCCN, the RTOG. There is a lot of overlap, though, but there's also some heterogeneity amongst these groups, and some heterogeneity in the clinical prognosis and the outcome of it. Typically includes some combination of 3 things that we all get, no matter really where we practice: score of the cancer, Gleason score, the exam, the digital rectal examination, and the PSA level. So it can be clinically localized. It can, in terms of T1, T2, or really T3. It can be high risk, so you can be high risk by just your Gleason score, and you can be high risk by just a PSA greater than 20. Approximately 10 to 15% of patients that come to see us or present with newly diagnosed prostate cancer in this bucket. There's a little bit of a change. It did appear that this is dropping if you look at the studies over in the early 2000s, but we think there's probably an increasing number of these folks that are coming in recently. So what about staging? So I think we'll start to have common ground, and you'll see the story that really the T3 disease from a clinical standpoint is what is defining high-risk localized prostate cancer. That's T3A or B, so B is into the seminal vesicle, and then the AGCC puts you in this group, and then they really give you an A, B, or C based on whether you have all the factors of PSA or just one of them. So let's compare some of the group definitions. So the AUA really defines this high-risk localized disease state as clinical stage T3 or greater, a PSA greater than 20, and a grade group 4 or 5, which we also know correlates to Gleason score 8 or greater. The EUA is really the same, so any of those factors you get into this group. The RTOG, which hasn't permeated as much recently, adds in one disease, also adds in Gleason score 7. if you've got these other factors. And then the NCCN took a little bit slightly additional approach. They have what they call a low and a higher high-risk group, really defined by the number of cores positive. So they put some emphasis on the volume of high-grade cancer. So excuse me, hang on one second, sorry about that. So really I just show this, that there's really a litany of options, external beam plus brachy plus endocrine therapy, external beam plus endocrine therapy, or surgery as first-line options in the high-risk group. You'll notice that the NCCN doesn't make a whole lot of distinction between being high or very high in terms of their treatment recommendation. Same story with the EUA. They obviously put radiation, which in 2018 is still somewhat of the gold standard. And then they also talk about high-risk locally advanced and high-risk localized disease with surgery being an option for treatment. So what is the reality? There's no consensus regarding the optimal treatment and management of high-risk prostate cancer. I think that's a fair statement. There's a lack of high-quality randomized trials and comparing the two modalities. And a lot of this is formulated by bias, by review of observational data and retrospective and case series. There's likely that no single modality is perfect, and then a lot of these are combination modalities. So what about some of the heterogeneity in outcomes? This is a study published a number of years ago that just looked at the varying definitions of high-risk disease. This was about over 3,000 patients. And then basically, depending on the definition of high-risk utilized, you could increase or decrease the size of the group included, and you can increase or decrease the progression-free probability. So how you define the population, define the outcome. So what about surgery? Well, historically, we have not done a lot of surgery for high-risk prostate cancer, at least in the United States. We kind of gave up that space because we had so much low-risk localized disease, and with the advent of the changing treatment paradigms for low-risk prostate cancer, we've kind of re-emerged and re-inspected this space. And there's a gradual accumulation of data. And then I've just highlighted 3 studies. I put these together to kind of show you what the largest retrospective series would show with upfront surgery in this disease state, defined by clinical T3, Gleason score 8, and PSA greater than 20, which is really the population I'm speaking about. There's about a 90% prostate cancer-specific survival, but if you track to the right screen, at least in the top study, a lot of people had adjuvant treatment. So is there a perceived survival advantage to surgery? Well, I hear this permeated a lot. I think there's some reality to it. They're very good local control. It's very uncommon for us to put ureteral stents in, to have ureteral obstruction and outlet obstruction post-surgery for prostate cancer. It does give you accurate pathologic staging. About 30 to 40 plus% will have a surgically confined disease. That's truly the bucket we're looking for, although the real home run is probably in the true organ-confined disease, in the hope that about that 20% you may get away with single modality therapy. I think that's very important to articulate to your patients, that most likely they're going to sandwich with an additional therapy, and then obviously just based on that disease state, a high rate of lymph node invasion, a high rate of T3B disease, and a pretty high rate of positive surgical margins. Just a couple other comments on surgery. There has been a suggestion, a hypothesis-generating suggestion. This is Matt Kuperberg's study from the CAPTURE database. This is all observational, that there's a reduction in prostate cancer-specific mortality with upfront surgery. This got a decent amount of press, was argued on both sides. They did a lot of fancy statistical methods to try to account for radiation versus surgery. And then there's been some suggestion that you may reduce metastatic disease. These are very hypothesis-generating. This is also came out, this was about 7,000 patients in the British Medical Journal, and really at the end of the day, it's suggested through this large retrospective analysis that maybe younger patients do better with surgery. The group 3 here is the same patient population I talked about, T3, Gleason 8 or greater, and then PSA 20 to 50 in this. So what about radiation therapy? I just got a couple slides to remind us of this. This is Michael Bowler's trial. This is obviously kind of the standard trial that most refer to that really set the stage for endocrine therapy plus radiation in high-risk disease with a 90% cancer-specific survival at 10 years. And then this is followed on this is really an adjuvant trial looking at hormones alongside in the adjuvant setting with radiation versus hormones at recurrence, and showed very good cancer-specific survival as well. So are there advantages to radiation? I think it's historically been, and probably in all fairness, is the gold standard. That's what started out first and had very good outcomes in high-risk disease. It certainly is a non-invasive option. It's very well tolerated, and there's little to no incontinence. So conclusions. Surgery and radiation are both reasonable options for high-risk disease, as defined as clinical T3, M0, Gleason score 8 or greater, which is now grade group 4 or 5, and a PSA greater than 20. Following surgery, pathology and serum PSA can help us drive the recommendations. I think we have to be very fair with people that this is usually the first step in a multimodal paradigm. Decisions should be individually utilized and discussed in collaboration in a multidisciplinary approach. And I think you really have to take into account patient preferences and desires. So just a couple additional thoughts as I end here. I personally favor radiation and hormone therapy for T4 disease. If I don't think I can remove the tumor, if I think I'm just obviously going to leave gross tumor behind, I favor giving them combination endocrine plus radiation. I favor an MRI. This has been over the last 2 or 3 years. I think for us that do a lot of prostate cancer, and certainly high-risk prostate cancer, the MRI has started to get us thinking about prostate cancer, kind of like kidney cancer, and has allowed us to really think anatomically about where the location of tumor is. Is this going to be a nerve-sparing candidate or not? And certainly, I used to tell people, I'm always doing a non-nerve sparing. Your risk of extracapsular extension is so great, but I do modify that a little bit based on the MRI results. You got to be careful about the bladder neck, so you got to think this is a thinking man's sport through this surgery. You have to use liberal frozen sections. You're trying to get negative margins, and you have to understand how to do an extended pelvic lymph node dissection. I think the people that do a lot of cystectomies may have an advantage in this boat. They're just more comfortable with extended node dissection. And I think for me, there's always a little bit of debate about the presacral space. It's not because the lymph nodes don't go there to a small amount. It's just that are you affecting the hypogastric plexus, especially if you're trying to render somebody nerve sparing on one side. So I always try to be really honest and upfront with the patient. I'm always trying to engage our radiation oncologist in the discussion. But I think when they do entertain surgery, a lot of them come with this really narrow thought that, hey, I want to have surgery, I want to get it out. Most of these patients, it is going to be surgery followed by some type of treatment. And we need to be very clear with them about this. And this is my last talk. This is my family. I have really appreciated my time here. And I think I got the translation correct. But anyways, your hospitality has been impeccable. Thank you so much for having me.
Thank you, Stefan. We don't have time for discussion at the moment, but please let me have one question, just one question. Nobody is splitting the very high-risk patients with the high-risk patients, and we know that since the modifications of the Gleason system, that the Gleason 8 is not traditionally very aggressive as it was before, because it has a lot of pattern 3 that moved to pattern 4. So Gleason 8 probably is not as aggressive as it was before, and we know before and at the moment that Gleason 8 is very different than 9 to 10. Nobody is splitting it, and you didn't split it too. So my question is, what is the right treatment for you at this moment with the evidence that we have for a young guy with a Gleason 9 to 10?
Yeah, I mean, it certainly is a quandary. I'd make 2 comments. The first is Gleason 8, low volume. I personally am a little biased, but I'm a big fan of surgery for that patient, because a lot of those will downgrade to Gleason 7, and they may get away with single modal therapy, which is a big win. 8, 9, 9, and 10, that disease for me is getting, if they haven't already had imaging, is getting them MRI, and if I feel like the disease is confined enough for me to surgically remove it, even if I think it's T3, and a lot of them will be T3, I will start with upfront surgery. But as I said before, I think you can make fair arguments on either side, but that's my bias.
Okay,
So Luis, can I just say, this is amazing. He gave his talk in 10 minutes. so that he could have some extra questions. So he's made up some time. So if there are questions from the audience. Pedro.
I have one question regarding the tumors located on transition zone. Sometimes they can have very high values of PSA, but they are, in comas, benign tumors. How you approach these tumors? Because sometimes they are very huge tumors.
Yeah.
And they pose questions regarding the margin on the bladder neck, but, it's a different biology tumor.
Yeah, again, so a lot of those we would find on pathology before. A lot of now we're understanding or seeing some of those on MRI and kind of knowing we have to go wide on the bladder neck. And that is definitely changing, for me, changing our focus. It's giving me a little bit more insight into who to do a really wide bladder neck on or not. So my bias, again, on those is, just from a surgical standpoint, is to be wide on the bladder neck, but MRI has usually helped to guide me a little bit more. But I do agree, those tumors in that spot tend to be quite a bit more
Because,
stable.
in my view as a pathologist, I think we need to redefine the risk groups in prostate using MRI, because no one was using it before. And second, the Gleason group grade, because, it's a way to overcome the changes on the Gleason that upgraded some of the Gleason 3 patterns to Gleason 4 patterns. And so if you use these two things, because, very uncommon, most of the tumors are not the big PSA raised tumors that were before when these risk groups were defined. So I think that's what we need.
Yeah. I think that's a good point. I think what you're saying is transition zone tumors that are Gleason 8 are probably a different entity than peripheral tumors that are Gleason 8, and I think that does make you reframe or rethink your treatment paradigm. So absolutely.
I'm not completely sure of this, because I'm collecting in this moment cancers from the anterior area of the prostate. Some from the anterior part of the peripheral zone, but many are from the transition zone, with invasion of the fibromuscular anterior area. And I believe it at the beginning that this from transition has a low Gleason, but has similar Gleason in, I'm speaking, not very small tumors. I'm speaking real clinical tumors, 2 centimeters, 1 centimeter. And I'm not completely sure if this is a rule that from transition has different biology. I'm not sure.
Yeah. I know there's been a lot of debate. I'll tell you the other thing that's obvious to me in MRIs, we're becoming much more sensitive to these transition zone tumors, because that's the part that MRI is really seeing, these anterior transition zone tumors, is a lot more of what we're finding, because we're sampling the periphery of the prostate. MRI is guiding us here.
Okay, so Stefan, thank you very much. So okay. Okay, so I'd like to say that it is more than a privilege and honor to share this table with Arnaldo and Dr. Derek, and I'm sure that Dr. Derek will make chemotherapy still very interesting.
Thank you. So Elizabeth, I said no to Edson, just so you know that. I said no questions. So we're keeping on time for Fernando. So I want to take a very different approach to my presentation, and I have to explain it to you. There have been some very interesting themes that I've heard since the last time I was in Portugal. You heard Cora say in Italy, the only way she can get some of the new drugs is in clinical trials. And several other people have said, I can't do this test, I can't do that, because it's no longer available. The system that I now work in is the biggest that I've worked in my career. I now have a cancer center that has 130 oncologists, medical, radiation, and surgical. We have 25 branches, and we see 17,000 patients new a year and about 300,000 follow-up visits. So it's a big operation, and my job is to kind of pay the bills. I have to figure out how I can do things. So if I use all my money for GU, then the ladies with breast cancer don't get treated. So what I want to do in discussing whether chemotherapy has a role is so different from the way it's been in my career, because when I started, chemotherapy, firstly, I think we agreed, didn't work. It was very expensive, And now we're looking at all the drugs that Elizabeth talked to you about that are horrendously expensive. A course of some of the drugs that we're talking about at this meeting, a full course can be $300,000, $400,000. And so there's no health system that is going to allow us ready access. I don't know the system in Portugal, and it really doesn't matter. I can simply say, if you look 5 years into the future, we simply cannot afford to do the sorts of things that we want to do. So I want to take you back about nearly 30 years to a study that I published, and it was looking at mitoxantrone. And the reason I mention mitoxantrone is I still review for most of the medical GU journals, and I saw a very interesting review from another reviewer recently. So someone had written a paper about chemotherapy in prostate cancer, and the other reviewer said, this paper is rubbish because this guy mentions mitoxantrone and nobody ever uses mitoxantrone today. And I think it's fair to say that mitoxantrone isn't used very much. And the reason I mention this is an old study when we didn't treat PET scan progression or MRI scan progression. We were treating people who had bone pain. Edson will remember this. Back in the old days, they had big lymph nodes that were palpable. And the reality is there was clear evidence of symptomatic benefit. So this was a drug that worked 30 years ago, and it still works today. And I'll show you in a minute why I mention it. I just remind you this is the Ian Tannock study that led to registration in the United States. It was one of the very first cytotoxics to be registered for advanced prostate cancer. And the reason that it was registered was it had to do with quality of life. And the quality of life for patients who were getting chemotherapy was actually much better than those who didn't get chemotherapy. Interestingly, this was presented in Journal of Clinical Oncology. This curve has been interpreted to say that mitoxantrone doesn't work because it was a placebo-controlled study, and you look at the two curves and there's no difference. This is why we shouldn't just read abstracts, because if you actually read the paper, what happened in this study is Ian and his colleagues allowed crossover. So what this actually says is not that mitoxantrone doesn't work. What it says is there is no rush to give chemotherapy. You can give it early or you can give it late after you've had a run-in period with placebo. And so this was an active agent. For a period of time, it was a standard. Some of you will remember the studies done by the Aventis group and the SWOG group, and I've summarized them there. These were randomized trials that were published back-to-back in the New England Journal of Medicine, and they showed very simply that docetaxel is a better drug than mitoxantrone in terms of survival. Now, I have to be honest with you, I was one of the principal investigators of SWOG at the time, and I predicted that there was absolutely no chance that this paper would get published in the New England Journal. And the reason was very practical. Look at the curves. They are definitely different, Edson. You can actually put your laser pointer and identify there's a small difference, but it really isn't a very big difference, and nearly everybody died. The New England Journal accepted it because it showed that there was a clinically useful outcome, and so docetaxel, or Taxotere, suddenly became the drug of choice, and mitoxantrone was then forgotten. And that's fine. Now, here's the point that I want to make. Just look at the numbers of the drugs and treatments that Elizabeth mentioned in her very elegant review of the sorts of options available to her. Whoops. That's a lot of money. Sipuleucel, too, in my experience, is a very useful drug for treating people who don't have active prostate cancer, but people like to use it because in America it's very expensive and people feel good about wasting money. But even so, look at the costs of these new wonder drugs. Look at cabazitaxel, and then look at mitoxantrone. Now let's just get that clear. Cabazitaxel, thousands. This is positively un-American. It's less than $100 a treatment. And so the point I would make, so the first part of my answer is if you have an old drug that is inexpensive, even if it isn't quite as good as some of the new drugs, don't throw it out as being completely useless. Again, look at the costs of the newer drugs. So this is the point that I'm trying to make to you. I'm not an apologist for chemotherapy. I'm simply saying that we're in the odd situation now where for systemic disease, chemotherapy has become, the old types of chemotherapy have become one of the cheaper options. Let's just look at some of the data that are available. Docetaxel versus a new wonder drug. You all know that cabazitaxel came in ahead of docetaxel in mitoxantrone failures. It was a randomized trial about 2 or 3 years ago. So they did a study that asked the question, does this drug do much, much better than this drug when there's a 10-fold difference in price? And the answer to the question is, there's a small difference in favor of cabazitaxel, but it's a small difference. If you then look at the question, what about dose? This is incredibly expensive treatment. So the standard dose created by the pharmaceutical industry, and I'm not criticizing the pharmaceutical industry, that was the dose they worked with. It's very expensive. So then investigators actually asked the question, do you have to use 25 milligrams per meter squared? Because with a very expensive drug over 6 courses, in my practice, I give 6 to 8 courses, generally maximum response plus 2. I have colleagues who say you have to keep chemotherapy going until progression. I think the data to support that view is rather slim. There's one study that supports it, but you can actually make a pretty good case for having holidays, and I'll show you why in a moment. So, cabazitaxel at 20 per meter squared versus 25 per meter squared, so that's a 20% difference in dose. Look at that survival curve. That's pretty unimpressive. Now, Edson, you'd agree, you can't see the difference with the laser pointer. So this is actually quite important. So they've demonstrated you can bring the dosage down without compromising patients. You actually, by bringing the dose down, reduce the level of toxicity. The PRINCE study, another important trial. I just told you, I believe in treatment holidays. My patients, I know, love me, but they love me more if I say, hey, how are you doing, and don't give them chemotherapy. So I get my maximum induction, and then I stop. And here's a study that asks the question, if you give continuous docetaxel versus treatment holidays, what actually happens? Again, pretty unimpressive. There's a minor improvement in continuous treatment, as you can see. But to be honest with you, I'm in my 60s. If I had the option, if I was unlucky enough to have metastatic prostate cancer, if I had the option of taking a break and coming to visit Portugal for 2 months in the middle of my treatment, I'd take Portugal over continuous docetaxel. And I wouldn't feel that I was somehow doing something stupid in terms of my survival. Another important randomized trial called FIRST-ANA. I don't know where they get these acronyms. And so this one was looking at Cabazi 20, Cabazi 25, and docetaxel. Big difference in price. Not a big difference in outcome. So the point that I'm trying to make, and it's such an important one, I come to Portugal thinking that what I have to contribute is philosophical constructs of where you should be thinking about taking your treatment. You guys are experts. I'm not here to lecture you about the use of things you do every day. What I'm trying to show you in this discussion of the role of chemotherapy is think about it in terms of using it sensibly and not forgetting that old drugs have activity. And you can see in this slide the level of activity, the median survivals are not all that different, but the prices are. Now, what about for the future? I think this is important. This was Chris Sweeney's study in which he asked the question, he actually asked it for all new metastatic disease, is there a role for docetaxel frontline? And what he showed is that for high volume metastatic disease de novo, it actually does make sense to use docetaxel with combined androgen blockade because there actually is, and this is quite a long period of follow-up, there actually is a meaningful difference in outcome. For small volume disease, I see no indication to bring chemotherapy in early. This study is quite important because what I'm hearing people say now is abiraterone or enzalutamide are better than cytotoxic treatment. I believe it's true that they are less toxic. I wouldn't argue the point, but look at the survival curves, and I would take Cora's point, you have to be careful in comparing groups, but just remember that this is from the Stampede trial from Nick James in the United Kingdom. It was designed to make these comparisons. The formal comparison with long follow-up hasn't yet come through, but if you look at these curves, it's perfectly reasonable to say there will be interchangeable roles in the future. So in summary, what I would say is I think chemotherapy will be introduced as one option in the frontline treatment of people with high-risk metastatic disease. The Stampede trial will eventually tell us whether docetaxel can replace abiraterone or enzalutamide or the other way around. There's no question abiraterone and enzalutamide are less toxic. With respect to the use of chemotherapy, my personal opinion is less is better. I interrupt chemotherapy when I can, when I've got a sustained response. I see no merit in continuous chemotherapy. The only people who benefit from continuous chemotherapy are the oncologists who then drive Ferraris instead of Porsches. I drive a Porsche and I'm perfectly happy with it, and I also interrupt my chemotherapy for my patients. So I think what I would say to the future is we have to be considering cost because it will determine everything we do in management. Thank you.
Thank you for very enlightening philosophical reflection on this topic, which is very relevant money. Is there any question in the audience to put to this?
Derek, you don't argue at this moment that the first-line therapy should be docetaxel versus abiraterone?
I think it's unclear. The Stampede study will tell us the answer to that. If I were a patient, and if the world would pay for my drug, then I would choose abiraterone over docetaxel. I'd rather take a tablet, I'd rather not have an injection, I'd rather not have peripheral neuropathy. I think the point I'm trying to make is that's my personal decision for me. If you're looking at the bigger picture, we may get stuck with a situation that will find us making choices that are about the amount of expenditure. In the United States at the moment, in order for the health insurance companies, the top 5 companies in 2017 gave their CEOs, their chief executive officers, cumulatively a bonus of $100 million. In order for them to be able to do that, there will be patients who will need cheaper treatments. Now, once we get governments that start to think more sensibly, I'm hoping that that balance will change. So at the moment, I would pick abiraterone or enzalutamide over docetaxel for frontline bad risk disease. For frontline good risk disease, I would use standard combined androgen blockade.
In the costs, you just mentioned the drugs. Do you think that the costs of supportive therapies like growth factors or the treatment of complications are not to be considered?
No, I think absolutely they're to be considered. And once again, I think it's a question of evidence-based. I was practicing in California with Don Skinner at the time. A little person came up to me and said, I'm a representative from the company that, I won't mention them because I don't want to get sued, the company that makes colony stimulating factors. And I want you to know, you are the oncologist who uses the lowest amount of CSFs in California. And there must be 10,000 oncologists in California. And he looked at me and I said, well, that's great news. Can I put that on my business card? And the reason is people use colony stimulating factors completely inappropriately, so very expensively to avoid things that often don't happen. In my career, I have never used G-CSF or any type of CSF for someone on platinum etoposide and bleomycin in the first 2 cycles. I've never done it because I know that I can treat them effectively and I don't get febrile neutropenia in the first 2 cycles. So the point I would make is you're absolutely right. Supportive therapies, we often use things that are incredibly expensive. I would call 1-800-Zeitman and say, Anthony, could you please irradiate this pelvic deposit? well before I'd use systemic treatment, because it's perfectly fine treatment and I can use my systemic treatment later. And because Anthony is originally British, his radiotherapy is cheap and it works very well. So the point I would make is it's all of the treatments we use, we need to be thinking about how much benefit do the patients get, how much will it cost them. In the United States at the moment, there's been, and I don't think it applies in Europe. Remember, we don't have a nationalized health system. In the United States, we have this system called co-pays. And people who have health insurance, depending on how much they want to pay for their insurance, will pay 10% or 20% of a copay. Now, if you make $30,000 a year and you have 10% of $500,000, you bankrupt your family. And in fact, one of the most rapidly changing financial toxicities in America is the toxicity of treatment. That's not the situation in Europe because you mostly have nationalized care, which is great. But as Cora said, she just cannot use new treatments in Italy unless it's on a trial. And not everybody wants to be on a trial. So we just need to be thinking about this for the future.
Derek, one more question. Well, in the castrate-resistant metastatic setting, we used to say that the docetaxel would be better for the most aggressive tumors as visceral metastases or Gleason 9 to 10. We do have any evidence of that docetaxel is better than the new treatments?
I don't think we have that evidence yet. You know, what I do think, and I'd be interested in Elizabeth's opinion and equally yours because you give chemotherapy, you know, what I do think is for any hormonal manipulation, what I've taught my fellows over the years is it takes longer for a hormonal manipulation to work than a cytotoxic. So if you have rapidly progressive disease, then I'll use something like docetaxel or mitoxantrone. And I'll make that choice depending on the patient, because I'll think about mitoxantrone for the patient who has cardiac irregularities in terms of rhythm. If it's someone who has cardiac failure, I'll use docetaxel. So I think it really comes down to the fact of having a medical oncologist who's working closely with the urologist who knows GU cancer, and then they jointly will make that decision. And in our center, you know, Stephen Riggs and Earl Burgess, who you've heard us mention, and our radiation team work very closely together. And we have a subspecialty GU radiation oncologist who does all our work, like Anthony does with his team at Mass General.
Okay.
So thank you. So just a short, so you use metoxantrone often? Is it the regular drug you use?
Yep. I use docetaxel more often, but I certainly am comfortable to go from docetaxel to mitoxantrone, or if there's a reason that I wouldn't use that, wouldn't use docetaxel, I'm quite happy to use mitoxantrone. First line. It's perfectly reasonable treatment. And as I said, in the United States and in the journals, many of the younger medical oncologists say mitoxantrone doesn't work because of Tannock's study comparing against placebo, forgetting the fact that they had crossover. And that's a crucially important point.
Okay, so thank you. So we move to the clinical cases. Elizabeth, please.
Dr. Pontus?
So the commenters, please.
Yeah, on the panel.
Esteban, Rouge, they come here, yes?
Yeah, they can sit. We've got chairs.
So as they're making their way up, I think we're going to go through the journey of one of my patients. And I'm not saying my answers are right, but at least it'll get us talking about what the different options are for such a patient. So this patient of mine who at time of presentation was at 62 years of age, was complaining of a lot of back pain for 4 months, tried to take some pain relievers, blamed it on snow shoveling, etc., until his wife kicked him to the emergency room because the pain was getting unbearable. And some smart resident in the emergency room took that family history, which you can see there. Patient was otherwise asymptomatic, was thinking he was going to get a muscle relaxer and sent home. But then the resident actually did a rectal examination, lo and behold, saying that, well, it's quite enlarged, although there's no nodules, no tenderness. and did a quick PSA test, which revealed it to be at 300. Subsequently, he was seen by an outside urologist closer to his home who did a 12-core biopsy, which showed at the worst score Gleason 9, 4 plus 5, in 6 out of the 12 cores, and it was bilateral. So the patient then was sent back for a consultation at our cancer center for an opinion, and we did some scans to see where the disease was, and unfortunately found some liver metastases and a ugly-looking bone scan. Don't need fancy testing to know that this unfortunate patient has metastatic disease. So the big question now is, after he decided that he wanted to seek care at our institution for his Gleason 9 cancer, what would be some of the appropriate next steps for this patient? And I turn it over to our illustrious panel to pick an answer. And I didn't make the choices very easy on purpose.
First, what is the age of the patient?
He's 62.
62. Okay. So
And I'll just mention he's 62 years old and he's African American.
to respect the guidelines, I use the androgen deprivation therapy and docetaxel in this case.
Would any of the other Would any of the other choices appeal to you?
No.
No.
Okay. But the question is a nice question. Is either you don't have any staging of the prostate. You don't have the MRI.
No.
No, nothing.
This
because
was,
I think it's very important because nowadays I need to know if it is there are some evidence that is important the treatment of primary of the prostate, radiation, or I'm not sure what is the staging, local staging of prostate cancer. I think it will be very important.
Just a question. Will you do a BRCA testing?
Oh, well, so this gentleman was seen in 2015.
Okay, because he
So
has a
let's think a
strong
little
history family
Yep, this
and
is
young
not-
patients and also a sister with breast cancer. So
Yep. So in 2015, nobody was sort of thinking that much about MRIs. His exam was, he was a T1C, slightly enlarged prostate, no nodules palpated, Gleason 9, 6 out of 12 cores, 4 plus 5.
I agree with you, Dr. Pedro, because this is a patient of important family history with breast cancer, and we know that BCR1, mostly the 2, is, and I know that liquid biopsy or in a specimen to analyze the
Right.
BCR. But in Portugal, we don't have this kind of test, but it's very important for not in this phase, but in after, if don't answer the first treatment that the androgenic deprivation therapy and docetaxel, I think will be very important for the next step.
Yep.
But we know that docetaxel also is a option for this kind of patient.
So in today's guidelines, as I showed earlier, the NCCN is recommending for metastatic prostate patients to be referred just in general, even without a family history, but obviously this patient has several risk factors, so in today's terms, using that hat, we probably would. So what ended up happening was this patient several years ago ended up getting ADT and survived his 6 cycles of docetaxel, really without much incident. He barely had any neuropathy, no febrile neutropenia episodes. So he had a little bit thinning of hair. He had some hyperpigmentation of where the IV docetaxel went through, which we sometimes see in our African American patients. But otherwise, he did quite well until 18 months later, his PSA.
Could I just
sorry.
stop you?
Yes.
A quick question, Elizabeth. So
Yeah.
I'm not arguing the case, but I'm just interested. So this patient was treated in 2015, which was before the publication of the Chartered study. So just take us through how you thought through that.
Right. I think the official publication came out later, but certainly was enough buzz in the circles, I think, where many of us who do a lot of GU oncology was talking about that. So for this gentleman, when there was a lot of metastases in bone and liver, and he was young at 62, we went for it based on not the final data set, but enough of a suggestion. And actually, I think it was a press release at the time, yeah.
Another question. You don't consider to treat the prostate with a radiation or?
Right, so and I think that is highlighting a
Because nowadays
Yeah,
probably
it's an
makes
emerging
sense,
topic,
makes sense
exactly.
to treat the
So can
the
I
primary
just
tumor.
step back a second? At ASCO GU this past month, I was chairing the session of whether you should do local therapy in the setting of metastatic disease. And I was fielding Adam Dicker and Mac Roach as they were fighting it out of who should yes and who should no. So I put up a question, though, for the audience, for you, those who were there, and it basically gave several selections. One would be surgery, take out the prostate, do a lymphadenectomy, the whole 9 yards. Another one was, no, it's going to be radiation and radiate everything. No, it's going to be radiation of the primary and radiate a couple of the small metastases in the lung and so on. The end result was in this 5,000 attendee group, 30% of which I understand to be international, it was basically 20% in each of the answers. So there were 5 answers and no general consensus. So I'm intrigued, and I'll ask you, if this was your patient, you would offer radiation? Why would you not
Yes.
operate?
I think it is most important is first to stage. I don't know if there are some nodes in the pelvic, there are pelvic nodes. I don't know, the staging is T2,
Yeah.
T3.
In this gentleman, there in the
Because
abdomen and pelvis, there were
I
no
think
nodes.
it will be very important MRI of multipalematic MRI. And this is very important for decision of operate or make radiation. But in this case, probably the best solution is radiation.
Dr.
Excuse me,
Pontes?
I'm representing Dr. Browse. There is a comment.
Do you think to stage properly the patient after the 6 cycles of chemotherapy, would you have a PSMA to see if there is a systemic disease? Because I think that local approach must be based not only in the answer of the chemotherapy, but also of the remaining disease. Because if you've got a lot of bone metastases, I think it's not correct to treat locally, okay?
In this case, I think it's not necessary. In this phase, I think it is not necessary. I think I need for a good staging, multiparametric MRI is very, very important for decision. But I know that is a metastatic case, a patient with a metastatic.
Sure.
And
But
I
these are
think
exactly
will
the
be,
issues.
but there are some benefits with in the radiation of prostate and pelvic nodes.
Yeah.
In this case.
Anthony, what do you think?
Well, if this patient were referred to me for
Yes.
radiation therapy, I certainly wouldn't radiate them.
You
I mean,
would
this is a
not.
man with extensive metastatic disease, and multiple deposits in his liver. I don't know why the lump of cancer in his prostate is more important than the multiple lumps anywhere else. I mean, it's nice to do everything that we can for a patient. And there are some situations where there is true oligometastatic disease, 1 or 2 metastases that you can see, well, I just might do it, although recognizing the evidence is very poor, and we're awaiting a randomized trial, which is several years from reporting. So, I mean, I think we have to we all want to do the most for our patients, but this is one situation where I personally would show a great deal of restraint.
Well, and can I just highlight that this gentleman had a nadir PSA at around 8 months of 30. So from his 300, he never became undetectable. So if you were to graph him, he literally bounced up after 8 months and started to sort of creep up, and at some point had an imaging scan, but really at 18 months worsened. Question in the back.
Did you check his testosterone?
He was castrate.
Below 50?
Oh, less than 20. Yeah.
Can I ask you
Yes.
Would you consider now to pick up liver tissue and send for a genetic testing like a Foundation One assay just to check if there is any possibility for some sort of target therapy?
Right. So that's a great lead into this, which is what would we do next? So I will turf it back to our illustrious panel to see what they would pick off of these different selection, including the liver biopsy or liver biopsy and send off for molecular profiling, abiraterone and prednisone immediately, enzalutamide, or cabazitaxel and enzalutamide together, because more is better. Thoughts?
In my opinion, there are some response to docetaxel. I agree with my colleague of panel and maintain the docetaxel. Why not? I don't.
Oh, wait, that's not even on the list, but you wanted a number F? That's cool. We'll put docetaxel back. Dr. Raghavan, would you give dosi again?
Absolutely not. I think you've read it not the way I think about it. So this is a relatively short period of response, all things considered. You've got rapid progression. I can't imagine why you would use docetaxel again or maintain it. You're just going to add toxicity without benefit. My choice here would probably be initial liver biopsy and molecular profiling. Not that I would act on it immediately, Elizabeth, but to have it in the hopper for later on, going to Pedro's point. I think you could make a case for trying abiraterone or enzalutamide. I'm unaware of good data that suggests that Cabazi plus Enza have a utility. I'd be happy to do it in a trial. Right. But I think having information on molecular profiling, if you have it available, would be useful potentially for later on. But again, so much of the molecular profiling information for many of the drugs is unproven. One of the points that Elizabeth made was the CARIS reports that we get, or the Foundation Medicine Partner reports, are very puzzling. And you have to remember, these companies are trying to justify their existence. So they'll make lots of recommendations, some of which are probably accurate, and some of which are unproven in the peer-reviewed literature. So I think I would do 2 of those.
Why not checking for neuroendocrine differentiation with chromogranin and neuroanalyze in this case?
Right. Well,
it'd be easier.
Yeah, and actually, we ended up biopsying just to make sure that things haven't changed. Again, this was a Gleason 9 cancer, although it was a 4+5. It was really there was a lot, 6 out of 12 cores. We've never had a chance to biopsy his liver, so we did, and it still remained as a prostate adenocarcinoma. But we did do molecular profiling, as Derek mentioned, and he did not have a BRCA mutation, but had an ATM mutation. So we did not jump on the next thing. However, here, back to you guys. What would be the next treatment option?
The option is olaparib or clinical trial with.
Right. So I think we often get into a quandary that there's testing molecular reports. Again, not sure what to put that in context, but You know, we have not tried any of the AR modulators yet at this point. The gentleman's only had docetaxel in the castrate-sensitive space. So any other thoughts on whether you guys would pick abiraterone or even Kabazi? Derek, what would you do?
You know, I think it would be reasonable to have a trial of abiraterone. It would really depend on the patient and how quickly things were changing. If I've read your presentation correctly, he has slow rather than rapid clinical progression. He's moving, so you have time for abiraterone to work, and I'd have the other guns ready to go, depending on what happened with Abby. I don't think that's unreasonable treatment. He's already been through docetaxel, so you know, there isn't any single absolutely correct answer. I personally wouldn't use docetaxel again. That's the only thing I do think.
Yeah. Okay. So actually, we successfully got him on a clinical trial with a PARP inhibitor, although I was a little, you know, I was happy there was a trial, and sometimes trials make it easy for you to sort of make that decision, but if we didn't qualify, I think that would be slightly more difficult. He did well for the first several months. He had some partial response on the liver metastasis. His PSA actually declined to as low as 8, and then he got worse again and had to come off trial due to new liver metastases and new bone metastases, and his PSA crept back up to 12. So at this point, let's see if we can move that. What's the next step? What would our panel do? Rebiopsy the liver again as he's progressed, and send new molecular profiling? Start enzalutamide or abiraterone prednisone? Do both?
Is is symptomatic or not symptomatic?
He is
very
symptomatic.
Important. Symptomatic? Why not? Another option is the radio. Some bone pain? Why not?
Yeah.
Eh?
Well,
I think it's not here, but in the answer. But I think it's a good option.
Well, it may be okay, but he has liver metastases, so that might not be so great with the radium alone, because it's only good for bone. Yeah.
My point would be that you had already invested on the patient, so keep investing on the patient. And why not to try to see if there is a new clone emerging with a new molecular profiling?
Yeah. Yep. Well, so we actually have that same line of thinking, and if my slide would advance one, I would tell you what we did. Of course, it doesn't want to advance. Hello? Oh, there we go. Yep. So we actually indeed rebiopsied his liver because his CAT scan was really markedly worse. He had normal liver function. He was not jaundiced, but this was the readout, and it was read out as neuroendocrine differentiation, not anaplastic, not small cell, but just neuroendocrine differentiation, of which it was at least 50% of the liver sample. So treatment options?
In this case now
Yeah.
is cisplatin and etoposide.
Etoposide? Anybody would pick hospice and palliative care as an option, since we're on the train of being fiscally responsible? Derek?
I'd make a case for carboplatin and etoposide. You know, the data from lung small cell suggests that carbo and cis are pretty interchangeable. And so I wouldn't argue about cisplatin. I think it's reasonable, but carboplatin is less toxic. At this late stage, I would worry a little bit more about myelosuppression with carbo, but one of the things there is all the crazies use an AUC of 6 because they do. You can get carboplatin to work at a much lower AUC, so I'd bring my AUC down and be pretty comfortable. One of the benefits is that's definitely outpatient treatment. With cis, he's more likely at this late stage to need to come into hospital, and I'd be trying to keep him out. So not opposed to cis, but I think carbo is another option.
And what about checking with the Dotanoc PET to see for somatostatin receptors and thinking about octreotide?
Oh, right. That's actually a really good suggestion, yeah. We haven't, so just so you know, I ended up starting him on etoposide platinum. He's had 3 cycles so far and is actually doing quite well. No episodes of neutropenia, no fever, and actually symptomatically feels better. We also increased his pain medication. But that sort of ends the case, and he's there now. I'm not sure if we're over time, but any other questions? Are we good?
So we're absolutely, Fernando, absolutely on time. This is clearly the best chairmanship panel that we've had in the meeting, because we have finished absolutely on time, and we will hold to that record. Let's thank Elizabeth for doing double duty. Wonderful presentation and interesting.
Thank you.